Now what we're going to look at now are the mechanisms and the anatomy of innate immunity, the non-specific type of immunity. And this is absolutely crammed full of important clinical considerations. First of all, it tells us how to keep people healthy by preventing them from getting infections. And also it guides us on how to start treating infections should people have infections in the first place. And this is good for general healthy people anyway, but for those of us involved in healthcare, many of our patients are at increased risk of infection because they're already poorly, or they have a wound, or they're immobilised, and that's going to increase their risks of getting infections. So if we know about these innate mechanisms of immunity, hopefully we can prevent many infections which would otherwise have occurred. And what we're going to do is just use this diagram and work down the body and look at some of these mechanisms of infection, some of these innate mechanisms to prevent infection, some of the mechanisms of innate immunity. So we notice that in tears there's a digestive enzyme called lysozyme. So lysozyme is an enzyme which will digest bacterial cell walls, and it's present in tears. And also the tears flow over the surface of the eye, and as they flow over the surface of the eye they can wash bacteria out into the nose. And also over the conjunctiva of the eye there's a thin layer of mucus which protects the eye from infection as well. So we've got a thin layer of mucus, we've got the flowing effect of the tears, and we've got the lysozyme which will help to digest bacteria. Now in the nasal passages there's plenty of hairs, and these hairs are coated in mucus, and the mucus is sticky and it will attract bacteria which are going through. So when you're breathing through the nose, the hairs in the nose and the mucus, bacteria will stick to them, preventing them from going down into the respiratory tract. The nose will also filter out insects, and it will also detect bad smells as well. So if food is off, we can detect it by the smell, not eat it, and that will prevent us getting food poisoning. Now, saliva contains commensal bacteria. Now, commensal bacteria are bacteria which live with us but don't cause any infection. They're kind of symbiotic. So in the mouth there's lots of bacteria, they don't cause any infection, we give them a nice place to live, but they are commensal, they're in our mouths. So what good is it to have a mouth full of bacteria? Well, because there's lots of what you might call friendly bacteria in the mouth, that means if any nasty bacteria or any nasty fungal infections come into the mouth, then the ecological niches in the mouth are already full. So the friendly bacteria will prevent colonisation with nasty, potentially pathogenic bacteria. They are commensal bacteria, they live with us. And the same is true in other parts of the body. The bowel, for example, is full of commensal bacteria, especially the colon. Absolutely full of commensal bacteria. Untold billions of them. But that's good because that means if any infection gets in, it's not going to get a place to live because all the houses, if you like, there are already full of people living in them. All the ecological niches in the mouth and the colon are already occupied, and that prevents infection. The vagina is fairly similar. That's got a lot of commensal bacteria in it, so that prevents infection from getting in. And this is why we can often get complications after antibiotics. So if we take antibiotics, that's going to kill off the infecting bacteria, which is good, but it's also going to kill off the commensal, symbiotic bacteria in the mouth, the colon, the vagina. That's why patients after antibiotics are more prone to getting colon infections. Clostridium difficiles, for example, much more common in hospitals in patients that have had antibiotics. Or fungal infections of the mouth and vagina again, can complicate antibiotic therapy because they're killing off the friendly commensal bacteria. So the commensal forms are good, and the mouth's got plenty of them. And also the mouth's got intact mucous membranes. Membranes line all of the respiratory tract, all of the gastrointestinal tract. It produces mucus, and the mucus prevents the bacteria from getting through, and it also means that the mucous membranes are nice and moist. And saliva also contains, like tears, it contains some lysozyme as well. And again, we've got the flowing effect. The saliva is flowing through the mouth, being swallowed, so bacteria don't hang around. There's no stasis of bacteria. Now, the respiratory tract, this is supposed to be the trachea here, but all the respiratory passages, of course, this breaks down into progressively smaller bronchial passages, forming the bronchial tree. And these bronchial passages are lined with mucous membrane, but it's a special form of mucous membrane, and it's ciliated. So what the cilia do is they waft. They'll go slowly in one direction and waft the mucus. They waft it along. So the cilia are wafting mucus from the lungs on both sides towards the trachea. And that means that the mucus is moving towards the trachea. It's called the mucociliary clearance system. It's using the mucus produced by the mucous membranes of the respiratory mucosa, the lining of the respiratory tract, and it's using the cilia to waft it. And that means that the mucus comes into the trachea, but you've still got to get rid of it from the trachea. That's why coughing is so important. So we cough, and when you cough, that will propel the mucus from the trachea through the larynx into the oropharynx, and then you can bring it into your mouth and you can decide to spit it out or swallow it, depending on what is most appropriate. So the mucociliary clearance system. And this works because the mucus is relatively fluid. And if patients become dehydrated, the mucus becomes tenacious and thick and doesn't clear properly. Almost like in patients with cystic fibrosis, where the mucus doesn't clear properly, it's too thick. So this is why we have to keep patients well hydrated, because if the patient's dehydrated, the mucus is going to be thicker, and as a result of that, the bacteria and mucus aren't going to be cleared. That means there's going to be relative stasis. And remember, of course, if bacteria are hanging around, the bacteria can double their numbers about every 20 minutes to half an hour. So it doesn't take long if the bacteria are static in the lungs for infection to start developing. And of course, we need the cilia to be able to move as well. We need good motility of the cilia. And smoking paralyses the cilia. So people that smoke, the cilia are paralysed for a while after that. That's why smokers cough a lot in the mornings. Because throughout the day they're smoking, the cilia are paralysed, then it's only when they go to bed at night that they're not smoking, and the cilia start working again, wafting the mucus from the bronchial passages into the trachea, and then when the smoker wakes up in the morning, they've got a trachea full of mucus, and they cough in the mornings to bring it up, and that becomes progressively worse over the years. So what we actually have in the respiratory tract is we have the mucous membrane here, made of the cells of the mucous membrane on a basement membrane, and the cilia are hairs that project from this ciliated mucosa. And there is mucus. Now mucus isn't green, I'm just going to draw it green. But there's mucus here produced by the mucosa itself. The cilia waft this in a particular direction as a result of the mucociliary clearance system. This means that if bacteria are inhaled or viruses are inhaled, they'll stick onto the sticky mucus, and rather than staying in the lungs where they can reproduce, they'll be wafted away to the trachea, where they can be coughed up out of the body and now unable in that situation to cause infection. So we need the mucus, we need the cilia, we need the coughing, and sneezing also does the same thing. The larynx, in the larynx the vocal cords will close, the pressure in the chest will increase in coughing and sneezing. Then when the vocal cords open, there's an explosive release of air, blowing air up from the trachea, and hence mucus from the trachea up into the, and this is the oropharynx here at the back of the mouth. Deep breathing also helps this system, so patients should be encouraged to take deep breaths as well. Now here we have the stomach. You can see the stomach here, lesser curve and greater curve of the stomach. And of course all sorts of bacteria can be present in the food which goes into the stomach. So in the stomach there's hydrochloric acid, which has a very high pH, well, a very low pH. It has a very high acidity. It's a very acid, low pH chemical, hydrochloric acid. And there's also digestive enzymes. And the acid kills the bacteria, and the digestive enzymes will break the bacteria down as well, protecting the gastrointestinal tract from food poisoning. But from time to time, food that's poisoned by bacteria can get into the stomach, and it can go through to the colon. Now, if that's the situation, we need to get rid of it. So imagine you've got lots of infecting bacteria in your stomach. Do you want to leave them there, or do you want to get rid of them? Do you want lots of nasty infectious bacteria in your stomach? Well, of course not. You need to get rid of them. And very often the body will do that. The stomach will contract, there'll be reverse peristalsis in the esophagus, and of course the patient will vomit. But very often in hospital, when people feel sick, we give them antiemetics, we give them drugs to stop them vomiting. And in infection, that's really exactly what we shouldn't do. It's a contraindication, it's exactly what we shouldn't do. So if someone's got infectious vomiting, we want to let them vomit to get it out, not give them antiemetics to stop the vomiting, because that means the bacteria will stay in the stomach. And the situation is much the same with diarrhea as well. If the mucosa of the colon is inflamed, then there's watery secretions, increased motility, the colon will push all the fecal material through, and we'll get diarrhea, flowing feces, diarrhea. And again, that's a defence mechanism. The diarrhea is washing out all of the viruses or all of the bacteria or whatever it is that's causing the infection are being flushed out, and that's the very best thing. If they're not flushed out, they'll stay in the colon. Remember that the bacteria can double their numbers every half an hour, and you can end up with rip-roaring severe infections because the diarrheal mechanism hasn't been working properly. And again, very often, so-called healthcare providers, when someone reports with infectious diarrhea, they'll give them something like Lomotil to stop the diarrhea, anti-motility agents. And that's the worst thing you can do. You want to get it out. Our role, if the patient is producing a lot of diarrhea in infection, is not to stop the diarrhea, but it's to replace the fluid and the electrolytes, to allow the colon to clean itself out, to get rid of the infection. So, yes, there's acids and digestive enzymes in the stomach. There's also commensal forms in the bacteria, commensal forms of bacteria in the colon. But if there's pathogenic, disease-causing organisms, we want to get them out by vomiting or flush them out with diarrhea. And we get this flushing effect in the kidneys as well. So the kidneys are producing urine, that's flowing down the ureters into the bladder, and that's flowing out of the body. So if someone's dehydrated, you're going to get less flow rates and more concentrated urine. So the lower the flow rates, any bacteria which do get into the bladder, the longer they're going to be there for, they're not going to get flushed out. This is one reason why we should drink plenty of water, to keep the urinary system well flushed out to help keep it sterile. Because if there's anything infectious there, we want to wash it out. And if someone does have a urinary tract infection or cystitis, infection in the bladder, they should be drinking plenty to wash out the bacteria. This flowing effect is very important. And in fact, we get the same in the gallbladder as well. The bile is produced in the liver, it goes down the bile ducts into the gallbladder, and if the neck of the gallbladder is blocked off with a stone, then the gallbladder can become infected, a condition called cholecystitis. Very, very life-threatening, very painful condition. Because there is no longer the flow. So the stasis leads to infection. We need to make sure fluids are flowing freely throughout the body, and no better example than the urinary system. So drink plenty of water. If someone's got infection, make sure they're drinking plenty. Physically wash these bacteria out of the body. So commensal bacteria in the colon we've looked at, motility of the colon we've looked at, one-way flow and flushing effects, because when the urine gets into the bladder here, the vesico-ureteric valves between the bladder and the ureters don't let the urine back up. So the urine can come down from the ureter into the bladder, but this valve stops it going from the bladder back up into the ureters. But this does happen sometimes. Occasionally children are born with defective bladder ureter valves. The vesico-ureteric valves between the bladder and the ureters don't work properly. Now, urine, actually, normal urine, very often isn't completely sterile. If you're drinking a lot, then the urine should be fairly sterile. But sometimes if someone's a bit dehydrated, like overnight, it's normal to have some bacteria in the bladder. Not a lot, but it's normal to have some. So children who are born with defective vesico-ureteric valves, they can have some bacteria in their bladder, and normally that will be washed out. But if the valve is defective, when the bladder contracts to void the urine, then the urine can go back up into the ureter. And that can go back up to the kidney, causing infection of the kidney, which is pyelonephritis. And this is very, very dangerous for young children, especially under the age of 5. The younger, the worse it is, because their kidneys are very sensitive to damage from infection. And they can get complete renal failure as a result of this. They can have renal failure and they can have high blood pressure as well. So if children are getting repeated infections, always think, oh, I wonder if it could be a urinary tract infection due to a defective vesico-ureteric valve. And test the urine for bacteria, and if there's bacteria there, then we can give the children low doses of antibiotics for a long period of time till the bladder base firms up and they won't get the renal failure because you've spotted it. So these mechanisms, if they're working normally, we don't give them a second thought. But if a mechanism like the valve between the ureter and the bladder is not working properly, then it can have absolutely dire, life-threatening consequences. And we need to be aware of that. So we've got the one-way flow system. As we mentioned, we've got commensal bacteria and acids in the vagina. The vaginal environment is very acidic, and that helps to kill off bacteria, and it helps to kill off potential fungal infections. Apparently there's some zinc in seminal fluid which gives it antibacterial properties as well. And intact skin is absolutely vital. Intact mucous membranes and intact skin. Now the integumental barrier of the skin is absolutely vital. If that's broken, then there can be infection. So wounds can become infected. Or if someone gets an insect bite, that can cause a local infection because it's piercing the skin. And insect bites can also let infection into the body as a whole. Malaria, for example, transmitted by mosquitoes, where the parasites get into the body and reproduce inside the body. It can cause systemic infection due to a breach in the skin. Burns are particularly prone to infection because there's a large disruption to the skin. But burns almost certainly are going to become infected if you don't manage them properly. Always with burns patients have a very high index of suspicion that infection is going to develop. And as well as the skin being intact, the mucous membranes that we've talked about also need to be intact. So if there's disruption of the skin, there's an open door for the bacteria and viruses to get through. If there's disruption of the mucous membrane, there's also an open door for the viruses or bacteria to get through. So for example, if someone's got pre-existing sexually transmitted disease, that can disrupt the genital mucosa, and that provides an open door, and then if they're then exposed to HIV, that's very easy for that to get in. So bacterial sexually transmitted diseases can disrupt the genital mucosa, making HIV infection much more likely. So the intact skin and the intact mucous membranes, the integument, the outer covering of the body, is very important, and when that's disrupted, we need to have a high index of suspicion that infection is a possibility. Keep an eye out for that infection, and if it occurs, treat it at an early stage. So there's some of the mechanisms of innate immunity, just a few simple implications of that knowledge that hopefully we can use to keep people healthy and to benefit our patient care.